Welcome everyone today to Vitel's Executive Webinar Series. Our presentation is entitled Lean Care Management and Automation. Our speakers today are Karen Handmaker, Vice President of Population Health Strategies, and Jerry Green, Vice President of Applied Quality at Vitel. Before we begin, I'd like to go over a few housekeeping items. First, you have a control panel on the right side of your screen. You may minimize or expand the panel by clicking on the arrow in the upper right-hand corner. Secondly, you can submit your questions using the question panel located near the bottom of your screen. We will try to answer as many questions as we can at the end of the presentation today. If you have any question that was not answered, we will follow up with you individually after the event. And finally, all registrants will receive a copy of the presentation, a link to the recording, and a white paper on lean care management and automation early next week. The information will be sent to you via email in which you had registered for this particular webinar. Next slide, please. I'm going to go ahead and introduce the presenters today. First, we have Karen. Karen is the Vice President of Population Health Strategies here at Vitel. She assists providers and health system clients achieve their strategic and quality objectives within Vitel's population health suite of products and services. She particularly is related to those patient-centered medical home models and value-based contracts. Karen is also a frequent writer, speaker, and trainer on issues related to population health and practice transformation in healthcare. Jerry, next slide please, is the Vice President of Applied Quality. She oversees various initiatives related to total quality management, Lean Six Sigma, Agile, Scrum, business analytics, clinical practice transformation, and HIPAA privacy. He is a certified Lean Six Sigma Master Black Belt and certified Scrum Master, as well as a certified project management professional and licensed professional counselor. With that, I will turn it over to Karen to begin the webinar. Karen, you may start.
Thank you, Renee. We're excited to have everybody on this call today. We have a great agenda for you. We're going to talk first, just to recap everything that I'm sure you're all experiencing, but to give you a recap of what's driving the changes in healthcare that we are all in the midst of, both in our jobs and as consumers, which is important to think about. We will talk about how lean principles and methodologies provide a foundation for transforming healthcare delivery. And at the end, we also will offer you a useful table for thinking about the 8 types of waste that Jerry is going to reference. That if you could eliminate those, it would certainly expand your primary care capacity and improve the patient experience and reduce cost, which is what the triple aim is all about. Now, Renee is going to do a couple of polling questions. Go ahead, Renee. The first question is asking, what kind of organization are you? Okay, we have a nice distribution on the call today. We have about 1/3 from health systems, 1/3 from physician group practices, and 1/3 in that great category called other. Next question. Please tell us what best describes your role. Okay, again, things bucket into thirds. 1/3 of you categorized yourself as being operational. Another 1/3 put yourself in the quality category, and 1/3 in other. We have 3% of you on the phone who are providers and 5% who are in IT. Next question. Are you currently leveraging lean processes in your organizations? %60 say yes, and 40% say no. We hope that this webinar will still be very meaningful and relevant for those of you who say yes, as well as for those who say no. Next question. Are you using automation to reach your patients? Okay. 2/3 of you say yes, and 1/3 of you say no. So we have some great ideas for you in this webinar. And the last question is, which HIT applications does your organization use? EMR only, EMR and patient portal, or the above plus other care management automation tools? Okay. 9% EMR only, almost 50% EMR and patient portal, and 42% of the above plus care management automation tools. Terrific. Thank you very much for answering those questions and letting everybody know the profile of everybody listening today. Okay, now we're going to start talking about the healthcare challenges. I would be shocked if everybody on this call hadn't seen a graph like this or a similar one, but it's always helpful to be reminded with a visual. This graph makes it very clear that healthcare spending is very much out of line with the growth in GDP and wages. And this slide is one that was in Health Affairs a while back, not too long ago, and it highlights some of the causes of waste in healthcare that can certainly be leaned out with the right approach, the right leadership, and the right incentives. Here, this slide has just highlighted things like failures of care delivery, failures of care coordination, and overtreatment. All of you on this call, I'm sure, both as working in health systems and as consumers, could identify others as well. And again, the triple aim is probably something that everybody is familiar with, but it's important to revisit it here. Don Berwick's concept became the framework and the cornerstone for healthcare reform. Very simply put, the triple aim focuses simultaneously on improving health outcomes for populations, improving the patient care experience, and reducing healthcare spending. This is a perfect setup for talking about lean, as you will hear in our presentation today. One of the things that's very, very important to drive the adoption of lean and care transformation is the fact that we are approaching the tipping point for toward value-based care away from fee-for-service. Even since we created this slide, there's even more organizations that have stepped up to say that they will be moving their contracts and contracting mechanisms toward value-based payment in the next few years. So with this tipping point, we will have many more organizations that have the balance of their contracts in these types of arrangements, which will drive the change that's necessary to achieve the triple aim. One thing that is extremely important, and by leaning out your organizations, you'll be able to address this issue even more. Not only will you understand it better, but you'll be able to deal with it, is that the idea of just focusing on the sickest patients, those who show up in your ERs and your hospitals, who have A1Cs and other indicators of risk and illness, if you just deal with those folks, you're not going to be able to bend the trend. In a volume-based world, it's easy to focus on those who are sick because they show up. In a value-based world, though, health systems managing populations need to find ways to identify and intervene with people before they get sick or sicker in order to prevent illness, acute events, and avoidable progression of chronic disease. Even those who embrace population health and already have a lot of value-based contracts still have a lot of learning to do, or even if they understand the concept, it's about how do I actually go out and reach those people. I don't have enough staff to do it. I don't know who they are, and I need tools, typically automation tools and analytical tools to help do that. Lean is going to help be part of that answer for everybody. Okay. In today's current world, although, as I just said, that's changing fairly rapidly for many of us, that one patient at a time environment, there's not enough time to focus on chronic care, care coordination, comprehensive primary care, being as patient-centered as many would like. Lean methods are very helpful for helping to create the capacity to do that. So before moving on to talk about lean, I think that's fair to say that we are still in transition. We are moving away from that volume-based episodic picture on the left and moving towards the right side of managing populations and understanding who they are, that they have, many people have chronic conditions, many have multiple chronic conditions, and these are the people that we need to identify that we're responsible for in terms of both cost and quality and patient experience. So now we're going to start the discussion about lean. I have one more slide to share with you about what we're seeing in the marketplace as we work with our clients. So here is a slide that shows that, that most organizations, and I'm sure this applies to most of you out there, that you already have lots of strategic drivers in place. You already have financial incentives that we've been discussing that are driving you towards population health. And as you said in the polling questions, you have already invested in certain infrastructure, whether it's the EMR, of course, or patient portal and other types of software and other tools. But the challenge is that many organizations are still in trying to build out this far right-hand side column, best practices for population health at the practice level. This is where you see the patients. This is where you identify the patients. This is where a lot of action happens and needs to happen in a population-oriented, value-based world. Lean is definitely going to help you transform care at the practice level, which will help you achieve your goals toward the far left. So, Jerry, I'm going to turn it over to you now.
So these three circles represent a very important concept. All three circles always intersect. You can't address one without addressing the other two. For example, often I hear people say, well, I believe the problem is training. We need to go train that team better and we'll get better results. When I hear that, it throws up a red flag because I want to go look at the technology they're using. I want to see how manual is it. Is it difficult to use? Does it have a lot of workarounds that are associated with it? And then I want to go look at the processes. Are the processes standardized around that technology? Are they fragmented? Is there a lot of tribal knowledge going on where each person or each group that uses the same process are a little different? Sometimes you'll find that there's only one person who can do one thing, and when that person's out, everything comes to a stop. So when I hear training, I want to look at the other two circles as well. And likewise with technology, if an organization gets a new technology, you not only have to train the people on how do you use that technology effectively, you also have to look at the process and determine how do I redesign the process to take advantage of that technology? How do I make sure that it's lean, it's focused only on the value add, and it takes the advantage of the automation that the technology has. All those three things have to align. Next slide, please.
Wait a second. There we go. Oh, sorry. Okay. This is a slide here that I was going to share with you before Jerry continues to talk about lean, just to remind everybody that at Vital, we really emphasize to our clients that quality is a function and not a project. Of course, we all do quality improvement projects as a way of improving defects, if you will. Uh-oh, what happened? Excuse me. Renee,
we can still, yep, we can still hear you, Karen, and we can see your presentation. Just go ahead and expand it.
Okay, there you go. Thank you very much.
Sure.
So the idea that we want to get across to everybody that's very important is that you have to develop a quality improvement function in your organizations that is empowered by executive leadership, that recognizes the details of your payer contracts and financial incentives, and that you have an active quality committee with cross-functional membership, and you continuously collaborate with your primary care teams to meet your goals. And at the same time, your quality team and your primary care teams need to have the tools and workflows to be able to do their job. That far right column I was showing you on an earlier slide. They need the line of sight, they need the data, and they need the tools to be able to activate those 3 circles that Jerry was talking about. Jerry?
So lean is cycle time reduction through waste elimination. And I like lean because if it's deployed correctly, you can hit the triple aim much easier, right? So by removing non-value added activities from a workflow, you can increase the revenue without sacrificing quality. And you can do that by repurposing the staff to the value added activities, right? They're not focused on rework loops because things weren't done right. Processes are going to be based on best practices, and the staff is focused only on the value add. It also ensures that organizations do not attempt to try to improve activities that should either be eliminated or automated. I see that happen a lot. You want to eliminate those or automate the manual processes, and then once that is done, once you've leaned it out, then you go and you try to improve the quality of the value-added processes that are left. And with the elimination of the non-value added activities, then you can increase capacity through a workflow or through an organization because, again, everyone's focused only on the value add. Next slide, please. So there are 5 steps to lean that have to be completed in order. Even if you're using another approach, such as Plan, Do, Check, Act, Plan, Do, Study, Act, or traditional DMAIC or others, those are great and those are fine, but when you're deploying lean, you have to follow these 5 steps. First, you have to define value from the patient/customer perspective. It has to be from their perspective. You can't pull it, you have to step out of yourself and look at it from what do they want, what do they consider value. Then you have to map the value stream, that's a visual, and identify issues and constraints in the value stream. That's going to identify areas where you need to attack and where you need to lean out. Then you want to remove waste and make the process flow without interruption. And what that means is, for example, if it's a clinic, it would mean that the patient would flow through without being interrupted. And we'll talk more about that in a moment. And then you want to allow the patient or the customer, you want them to pull value through. You want their needs to pull what's going to be put into that value stream. And then you want to maintain the gain and pursue perfection. Okay, next slide, please. Step 1 is define value from the patient's perspective. Next slide.
Okay, so I'm going to take a shot here at giving you a little intro to what Jerry's going to talk about. In a PHM model or a population health management model, it's important to consider, as I showed you on the iceberg slide, the entire population, not just those who are at the far right who are catastrophic or make their appointments and show up for care. It's very important to have the tools to stratify your population by different criteria, some of which is based on cost or could be based on conditions, could also be based on psychosocial needs or socioeconomic criteria to help you understand and devise a way that you'll be able to manage every segment of your population effectively. Here's a model that just shows you an example of how you could apply automation to manage different levels or different strata of patients. So, for example, the catastrophic are likely to need case management and much more hands-on help from your care teams, as well as quite a few of those with multiple chronic conditions. But as we move to the left, those who are at risk and those who are well might be able to benefit from a blended approach or a fully automated approach where using mobile tools, using interactive or asynchronous communications, using automated messaging could really help leverage the care team's resources and engage patients and keeping them involved in their health care so that they don't progress further to the right. Jerry?
All right, so the Kano model, it was developed by Nariki Kano in the 60s, is an industry standard technique that can really ensure that you don't leave things on the table when you're trying to understand what's important to your patient or to your customer. I really like this tool. We use a brainstorming technique around that works very well. So the basic needs are those needs that a customer will not specifically ask for because they assume that it's going to be there. And the example I like to use is if you buy a car in Texas, you can have a lot of bells and whistles on it, have a sunroof, it can have a DVD player in the back, nice tires, nice wheels, but if it doesn't have an air conditioner, none of that's going to matter. And customers don't walk in and say, hey, I want an air conditioner in my car in Texas. Now, if you live in Alaska, they may not have an air conditioner in it, right? So the basic needs are those things that you don't want to forget. You don't want to just focus on the things that the client's asking for, the customer's asking for, like the expected needs. Those are the things that a patient or a customer is going to explicitly say, this is what I want. Then the wow factor items are those things that the customer or the patient doesn't realize exists yet. There's a technology that's new that they don't know is there, and when you offer it, they're wowed. But again, you can give them a wow factor, and you can give them what they're asking for, but if you don't meet a basic need, they will be satisfied. If you meet a basic need, they will not be satisfied. So I'm not going to pat you on the back for doing something that's basic, but if you take that away, then they're going to be dissatisfied. So when you develop your lean process around your new technology, you have to make sure that you're not forgetting some basic things that the customer is really going to be looking for, but they're not going to tell you about it. So that's basic. And this is, again, a technique we use around brainstorming, where we pull subject matter experts around. You can even bring in patients and customers and ask them what their needs are, and then you can categorize those. And when you're done, just make sure that those needs are not forgotten as you design your new process, especially the basic ones. Okay, next slide. So the next phase in Lean is you want to map the value stream and identify issues and constraints. Next slide. So you want to map the value stream, and I highly recommend using butcher paper, big paper, and sticky notes. And the reason for that, number one, it engages the team. It gets everybody around the map, off their cell phones, off their laptops, up around the map, and critically thinking about what are the steps in this process. And you want to be the thing flowing through, or the entity flowing through. So if it's a clinic, you want to be the patient, and you want to map out every single thing that happens to that patient as they flow through. Not focusing on what workers are doing, but focus on what is happening on the entity, or the customer, or the patient, whatever is flowing through that value stream. And I like that approach because it becomes a visual. It becomes part of your change management strategy. It becomes a sense of urgency. As you can see in this map here, this is a real map, and you can see there's areas of complexity that are highlighted. So you know this area has to be addressed because it's complex. This is where your rework is going to occur. Things are going to slow down. There's going to be bottlenecks. The flow is not going to continue without interruption. And you can see there's another area where there's loops going back. Those are the rework loops. That's because something didn't happen right. The patient came in not having an order done, or something wasn't done correctly, and it's causing a rework loop. So when something has to loop back around, the second time through that loop, it's non-value add. The first time may be value add, but when it comes back through, that percentage of time is called a hidden factory. What that means is there's a percentage of time that resources are being spent doing something again, as opposed to just doing it the first time and having it flow through and out. So that's a very important concept. But I like the map visual because it's a change management tool, and it really allows people to see where some of the problems are instead of just speculate. Next slide, please. There are 3 criteria in Lean that will help determine if a process activity is value add or not. All 3 have to be a yes. If any of these are a no, then it's non-value add, and it should be targeted for elimination, simplification, or automation. And those 3 things are: the patient has to care about it, or the customer of the process has to care about it. If the patient doesn't care about it, then clearly it's not value to them. Okay. The next is the activity must change the patient or knowledge about the patient, right? It has to change the thing that's flowing through. If it doesn't change anything, like filing something or inspecting something, just looking at it, then it's not providing any value as well. And then the activity must be done right the first time. So if it's an activity that's due to a rework loop, then clearly patients or customers don't want to pay for something that should have been done right the first time. Now, as a note, when you go through the map, every single activity you should apply these three concepts to, and you should label them. If it's non-value add, put a red dot on it so the team can come back and look at it. Every activity. Don't forget the lines. The lines in a map represent a transition from one activity to another, and they too can be non-value added, right? Transportation or wait time can be in that line. So you want to make sure those are evaluated as well, not just the activities that are in the map. Okay, next slide, please. So there are 8 wastes in lean. And this helps understand the type of waste, helps understand, the solutions that can help mitigate those. So I like to look at my map, and where there's non-value add, I label then the type of waste that it is. And it can give you an idea, if you time it out, what percent is due to defects, overproduction, waiting, all these things here. And it'll give you an idea of what you need to go after first. So the 8 wastes, you have defects. Those are things like incorrect data, incomplete information, and these things, an acronym of downtime is what we use, and there's others that other people use as well, but I like downtime. Overproduction is extra reports that people make but nobody reads. Then there's waiting, which is like batch processing, not processing something when it's needed, sending something to the next activity when the workers and the resources are not ready for it yet. Then there's unused creativity, which we think of as not working at the top of license. And I changed that up a little bit recently, and it's not just the top of license, it's not working at your legal allowability. And the reason I like that better is because not everybody in a clinic, for example, has a license, and not everybody in every process has a license. So it's working at the top of your legal allowability, so you can balance resources in the organization as things ebb and flow. Then there's transportation. All the lines on the map are transportation, right? Traveling to and from a facility, traveling to a lab, walking to a copy machine. I've seen situations where there was a lot of non-value added time added in the day because people had to walk quite a ways just to get to a copy machine and back. Inventory is purchasing supplies in bulk, storing them. Motion is a little bit different than transportation. Motion is when you're in an area where you're just moving a lot. You're reaching down, you're taking a step here, a step back, and you're moving around. That's motion. It's a little bit different than transportation. And then excess processing is usually the biggest one in here, except maybe waiting. So multiple processing is where you have multiple sign-offs. Most meetings that don't provide value are extra processing. Downstream inspections because something's not done right up front, so we have to put an inspection downstream. Rework loops are extra processing, and then any extra approvals or things like that. Okay, next slide. The third step in lean is to remove waste and make the process flow without interruption. Next slide. So this is a value stream that's mapped. Once you've mapped the value stream in its quagmire state, we have all the non-value add. Then your team wants to come down and to remove that value add, see what you're going to automate, what are you going to simplify, and produce a to-be map. In this case, this is a perfect process. And it identifies areas where you can eliminate the non-value add, where it's going to flow better. You remove the bottlenecks out of the process map, and you may even add some things up front that may look like a little bit more activity, but downstream it alleviates work downstream. And this is what I'd call a to-be map, and that's the next phase. Again, it's a nice visual to show this map next to the map that had all the issues in it, so you can put together a plan on how do I get from the current state map, the as-is, to this map, and that was where your action items would come in. Next slide, please.
This is a slide that we put in here that we think you can all relate to. It's an example that of a common challenge that creates a lot of waste in terms of redundancy, in terms of just stopping in your tracks to figure out what I'm trying to measure and what the differences are between all the different measures and how many measures are associated with every possible condition that one of your patients in front of you has that you might need to be thinking about as you treat them, or as you develop or create cohorts of patients that you want to reach out to improve your quality measures. Every single contract and condition has so many measures associated with it that this just screams out for a lean approach to rationalize it. So while the industry debates how to rationalize a core measures list for population health and value-based contracts, which there is a lot of talk right now about it, and things are happening, but I think for the immediate future or the foreseeable future, many organizations are going to need to use automated tools and analytics and other ways to make this, as Jerry would call it, almost a quagmire, into something that is rational and improves the system and drives value and not waste.
All right, the next step in Lean is to implement the solution and allow the patients to pull value. Next slide, please.
Okay, and this is a slide that I think is very helpful. So if you can imagine, if you think about all the spaghetti maps that we showed you before, and we showed you all the measures and people not knowing how they're doing on any of those measures or how to keep track of all of those things, the foundation of a Lean process, or what we call a bottom-up model, to help you drive scale and improvement starts with data integrity. It means knowing the data about every patient is accurate, that all the reports are being trusted by the providers and the quality team, so that when you say that this practice is doing better than another, or the percentage of patients that have uncontrolled diabetes is this percent for this physician and this another percent for another physician, that people understand it and agree with it. Once that happens, then everybody can have the same line of sight. So everybody knows how they're doing, they know what the goal is, and they know what they're trying to do to get there. Then you can enable your care teams. Then the care teams, they have the information that's built on that foundation, and they know where they're going. Then they'll be able to manage the patients more efficiently, whether they're managing one patient at a time or they're managing cohorts of patients. Even patients will be better off because the care teams will know more and have more tools at their disposal to be able to engage patients and educate patients, whether they are sick or whether they are well, about how important it is to manage their health and continue to do that. And then ultimately, all of these things add up to improved quality. We at Vital clearly believe, and I think we've given you quite a few examples so far, and we'll talk more during this webinar about it, but the only way to scale at this level is to have what we call intelligent and accessible technology. So that means that if you think back to what Jerry was saying a bit about top of license or top of what's legally allowed, you want to be able to let your technology tools become, in effect, members of the care team, doing what the technology can do best and not trying to ask humans to do what technology could do better, especially humans who are particularly highly trained to do care management and health coaching and to listen to patients or to treat patients or diagnose patients. Let the technology do things like create the cohorts, identify who has care gaps, make the automated phone calls to people to remind them to make an appointment with their provider or to get a screening test. So think about how all of that would go into your value stream as you design your 2B processes.
So this concept bakes the noodle. It really does. We are taught to always be busy and to make sure everybody's busy all the time. But the Lean concept challenges that and says, wait a minute, all we care about is the work, the thing flowing through. That's what should never be idle. For example, if a patient is flowing through a clinic, you could probably step out in the area and look around, and you're going to see everybody is busy. All the workers are busy 99% of the time. But if the patient flowing through or whatever's flowing through a value stream stops and waits, then there's no value being added to that entity or that patient that's flowing through. So it's a concept change. Think about what's happening to the thing flowing through the process, what's flowing through the value stream. Not so much are the workers busy around the value stream. In fact, it's probably better if workers are only busy about 85% of the time. It gives them time to refresh a little bit. You know, if you're working 100% of the time, that's pretty busy. So think about the work and focus on what's happening to the thing flowing through. In this case, if it's the patient, Focus on what's happening to the patient, and is the patient waiting or idle any time during the process flow. Next slide, please. So watch what is being worked on, not the workers. Don't focus on how busy the workers are. Focus on the thing that's flowing through the process. Also, consider using WIP limits, okay, so that patients don't become backlogged waiting on each other, right? So you want to make sure you flow it through so that one patient makes it all the way through without waiting, right? Now, keeping workers busy is very important. I understand that. You know, people have to have things done, and there's things that have to be done that are very, very important. If that's the case, ensure that as soon as the patient arrives, all other work must cease and work must begin on the patient immediately, okay? An example, if you go to a restaurant and you see that everybody's busy in the back cleaning or working or taking inventory, they're all busy, but if you're at the table waiting and not being waited on, that's not value add, right? So you want to make sure that everything stops, all the workers come around and swarm around the patient or whatever the entity is that's flowing through and immediately addresses that. Then go back to the other things once the primary entity, the patient flowing through, is worked on. Say everyone must work at the top of their license or legal allowability, and the reason that's important is that will allow ebb and flow. As things ebb and flow during the day, workers can swarm where they need to in order to ensure that the patient flowing through never waits. Next slide, please. Also, this concept is very difficult to understand sometimes, especially just on one slide. So I'm going to try to explain this in detail. Never push any entity to the next step in the process when workers and resources are not ready for it. All you do is move from one waiting area to a next, and as you push it downstream, the patient or whatever you're pushing downstream, you lose visibility of what's happening. You don't see that person sitting there, so you lose visibility of what's happening downstream in the next area. Always pull through, and this also includes items like supplies and things that are needed. You don't want to order more than you need. Let the patient determine what's needed. Order and only replenish what is taken and used. And I know that sounds easier than what it is because sometimes that may include negotiating with suppliers, using your schedule a little differently to try to determine, you know, what was used yesterday, what was used the day before, because that can vary a little bit. But try to allow it so that the patient is what's determining what gets used as far as supplies. Don't over order and just put those in a cabinet. Okay? So as you pull, each one of those sticky notes there represents a patient, and as you pull them through, you want to pull them to the next level. You can eliminate the waiting areas if you just pull them through and schedule so you're pulling them to the next level, and you don't pull them in until everybody is ready and all the resources are ready, the supplies are ready. Then you pull them into the next level from the backwards forward. And also, this is very helpful to make sure, again, everybody's at the top of their license so that if there are areas where there are bottlenecks that are occurring, individuals can step in and try to keep the patient from having to wait, the thing flowing through without interruption. Okay, next slide, please. Step number 5 is maintain the gain and pursue perfection. Slide.
Okay, so now after you've gone through a lean exercise and you have developed new process maps for what we call the to-be process, the idea is, as I said in an earlier slide, you want to have a continuous, ongoing quality improvement function. That's part of your DNA. It's not just a project to fix something that's broken. That's built into the process, actually. So to maintain the gain, you need to have in your primary care practices workflows that intersect with quality continuously. So you have people in every area working at the top of their license, understanding the handoffs, having the data they need. So you would have your planned care team that manages the patients that are coming in for visits, helping to schedule visits for patients who don't have them and need them, scheduling tests, doing care coordination, and managing their general needs. And then you'll have the complex care team that would for example, take care of those higher risk patients, would collaborate with the planned care team when those patients have visits or might need other services when they are in the office for a visit. And the complex care team might actually not be physically in the office. It might be a centralized function. It might be within your health system. It could be in your, if you have a health plan in your system, it could be there. If it's part of just a centralized shared services function to share across all of your practices, it could be there too. But the point is that there still are communication links between the complex care team, so they're constantly doing what they're supposed to do. They have their eye on the ball, and then they can interact with the planned care team when those patients need to come in for visits. And all the while, the quality management function is looking at reports by measure, by payer, and looking at where there are variations, where there are deviations from what you would expect, and doing problem solving, and that all of that integrates with what we call processes that are working in flow. Care teams that are all empowered, and automation is helping to optimize everybody's capabilities. Definitely a to-be state for most of us, but if you have this visual, it helps you understand what you're trying to achieve. Terry?
So finally, you want to pursue perfection. So after you've made a few changes in the processes and with your technology, you want to remap it again. Remap the as is, let it run for a few weeks, maybe a couple, 2 or 3 weeks, and then remap it again and see what it looks like. See if there's any additional quagmires in there, if there's some rework loops, if there's some bottlenecks where the patients are getting stuck in the process. So remap it again to see are there other things that you can do, to ensure that the patient flows through without waiting. Once that's done, document it. Ensure version control, right? Easy access so that people can get to the documentation and the training for that area. Especially if you bring people in and you move people around, it's nice to be able to go to one place to see, hey, this is how we do it. Then you want to leverage the best practices across the enterprise, right? So hopefully this was just one area. Leverage the best practices across the enterprise. And then go back and then specify value from the patient's perspective. So you'd want to start over, see what's the value, has the value changed, what's important to a patient. And then measure success, redefine new and tougher targets, and that's really what pursuing perfection is, to never stop continually trying to improve, not letting good get in the way of being great. So, all right, next slide. This is your slide, Karen.
Oh, I'm sorry. Okay, so as we promised at the front end of the webinar, we were going to share some ideas for leaning out the 8 types of waste. And when you get the slide deck after the webinar with the recording, you'll be able to look at this table that I'm about to show you and study it in more detail than we're going to go over here. But we thought it would be very helpful to understand or to give you some examples of what we're talking about within the realm of primary care. So, for example, defects is the first one. Defects are errors that can result from omissions or inaccurate information or just plain old mistakes. And that causes rework, and really, as you can imagine, if you just picture yourself in a busy practice, how easy it is for defects to occur. So one of the ways that we can help minimize that is to use algorithms to evaluate care gaps and not have people try to figure it out just by eyeballing a chart. Overproduction. That means providing more services that are needed, including redundant services. One of the things that healthcare reform is trying to do is minimize duplicate services. When people go to 2 different providers and have the same test and the providers are not aware of it, otherwise one of them might not have ordered it. So those kinds of things are very important. So to be able to have a patient registry that shows you a complete 360 picture of what's going on with the patient across your community would be ideal. Waiting. Waiting is something that is, to make a little bit of a pun, a chronic condition in many healthcare practices. Idle time for the patient, which is a huge dissatisfier, would not fly well in the Kano model that Jerry described. It's idle time usually due to somebody waiting for needed information, waiting for a patient who is ahead of the patient in the queue at another step that is holding up that patient from being pulled through. So in some cases, some solutions for this could be some same-day appointment to improve access, redesign the visit prep process, using daily huddles to prepare the care teams more, even preparing some of the supplies that are needed in the patient exam room so that there isn't time wasted looking for different things that the nurse or the doctor might need while talking to that patient. Unused creativity. This is a huge challenge in healthcare because in the work that we do, we often see highly trained nurses spending time trying to figure out Excel spreadsheets and looking at measures, figuring out who has a care gap. There's a lot that you can do to train medical assistants or even delegate to an automation tool to be able to identify all those patients that have care gaps and help you plan your day with pre-visit prep, or to identify a cohort of patients that need to be communicated with because they're missing a mammogram. So unused creativity means that taking off that wasted effort that could be done by another person or another tool, and then allow people to do what they do best. And then the other four types of waste are here. Jerry already talked a bit about transportation. A lot of it is even when you are sending somebody down the hall for a lab test, or even if you as the provider or the nurse need to go down the hall to a closet or to another room to get supplies and come back to the exam room. That is potentially wasted time where you could be pulling a patient through your process much faster if indeed those steps were eliminated. It is actually amazing, and one of the slides we showed you that looked like a spaghetti diagram, which it was, if you think about it and you actually map out all the steps you do using a pedometer, it is shocking how much time you waste every day, and multiply that times the number of hours or number of days or number of patients that you could be doing something else, or how many more patients could be fit into the system if you fixed those types of transportation waste. I think inventory we talked about quite a bit, and Lean offers some really fun systems called a Kanban system or a signal system, so that when you're running low, you automatically know what to reorder and how much to reorder. Motion. Motion is what Jerry talked about. A lot of times it could even refer to extra clicks in a system or trying to click through 20 screens to figure out what's going on with a patient instead of being able to see it all in one place. Another thing that we see a lot is for primary care practices that have the ability to do this are redesigning their physical layout so that the medical assistant and the doctor, for example, that they're teamed with, literally sit right next to each other in the same pod so that they can be communicating during the day. They are not stacking up notes and memos to put on the doctor's desk during the day that the doctor then has to go through one at a time. They're doing things in what we call in flow, so one at a time, so there's never any batching. So think about all of the motion that you waste when you are when you are having to go down the hall just to talk to somebody or show somebody something to get their approval, when it could be done right there on the spot. And then excess processing, more work than is being done. It could include rework. It could include asking the information. How many of you have gone to a doctor's office and had to put in all the information about yourself all over again instead of just updating what you had already given them? So think about that as you're going through your processes and as you're experiencing the healthcare system yourself, and it will really help you to think lean. Okay, now we're ready to go into questions.
All right, great. Thanks, Karen. At this time, we will go ahead and start populating some of the questions. As a reminder, if you just click on the plus sign to open up your screen where it says questions, you can go ahead and type in your question there. We will pause for a little bit and go ahead and answer those. And I just want to let everybody know, as a reminder again, we will hand out the slides as well as a link to this recording that will be available to you in your email. You should receive it early next week. In addition to that, on slide 40, Karen showed you a reference at the bottom. That is a link to the white paper that will also be included in the webinar. It is a white paper that Karen and Jerry wrote on lean care management and automation. And that references also the 8 steps grid that you also saw.
Okay. All right, so one question that that was asked that I think, Jerry, you would be good even after this discussion for you to go back and help with is, can you give a little bit more background on Lean? 40% of the people on the call do not use Lean in their organization, so maybe they just need a couple more points about the history of Lean or the background and why it's relevant in healthcare today.
Okay, so that's a good question. So Lean started out as part of the Toyota production system, and Toyota built, their factory so that everything was lean. When they started, it would take them 3 or 4 days to move out a paint machine so they could paint a different color. So they'd only paint one color on each day, right, because it was too hard to move it out. Today they've got it where it just takes a few minutes in order to do that. So you can have a special car being produced at every single station going down the assembly line. That's Lean, the Toyota production system. It's been applied now to transactional areas such as healthcare because the concepts really work well. And I really like Lean because it's easy to deploy, and the focus on Lean is to remove non-value added activities and repurpose workers on the activities that provide value. So it increases the velocity of things that are flowing through. And it also addresses things like constraints. Where are the bottlenecks in the process? Uses things like spaghetti diagrams that Karen was talking about. Where are there a lot of motion and wasted time? In a Lean process, it gives you line of sight to the customer's needs because there's not a lot of workarounds and things going on in the process that do not add value. So that's really the crux of Lean, is remove non-value added activities and repurpose all the workers on the value add in order to increase the quality of care and to increase the velocity that flows through. And also with Lean, you want to lean first so that individuals aren't spending time trying to improve activities that are non-value add. Thanks,
Jerry. We just got a really good question about how to motivate others to get on the Lean bandwagon. This is something that, if you recall the slide at the beginning of the presentation with the circles on it that were intersecting with it had one for people, process, and technology. Well, within the people segment, there's the requirement that there is leadership, and not just at the top of an organization, but throughout an organization. It's really important. In fact, without it, your Lean investment will not take. You need to have champions and people who are trained in Lean or understand enough about what you're trying to achieve in the practice that they can be there as practice coaches, that they are the type of people that motivate others, that are leaders themselves, and that will carry the flag, so to speak, executing on the vision of the executives of your organizations.
And I would like to add to that, Karen, because that was excellent. The other thing you can do is when you're going to deploy Lean, don't choose a project at first that's really, really hard, right? Get a short-term win. Even though it may not have the huge impact that a project that's going to take 4 or 5 months could have, find something that you can do in the short term, within a month, within 30 days, no more than 60 days, where you can get a short-term win, because once you get that short-term win and you get value from that, then stakeholders start to see the value of that, and they'll be more motivated to see what it's going to do next.
That's really good. We have another question here is, how do I start? Most of our contracts are still fee-for-service, but we know that that we will have more value-based contracts down the road. It's really important to have your executives acknowledge that this tipping point is definitely going to occur, and you need to prepare, even though it's harder to prepare before everybody feels that pain of change, if you will, and understands what's happening. So it's, again, starting small, getting some quick wins, thinking about using one contract, like many organizations, even though it is very difficult, started with Medicare ACO contracts. Others have started by picking several practices to become recognized patient-centered medical homes, to transform to be for example, an NCQA recognized medical home. Lean is a recommended process, not necessary, but definitely desirable to use to help transform practices to meet the patient-centered medical home standards, to build that foundation. When you have those successes, then you're going to be in a better position to scale as you get more value-based contracts and as more of your patient population is touched by these contracts. Jerry, did you get any other questions?
I did not.
Okay, so I think that there is, just in closing here, we got some good questions, and if you have others, please feel free to share them with us later. Renee is going to give you our contact information. But the idea that that's so valuable about Lean and thinking about automation is that ultimately it makes everybody happier. It's going to sound funny to say that, but there are even articles that are written about the joy that people experience in working in a primary care practice after these Lean processes have been developed and applied. Everybody has a hand in developing the processes. Everybody understands why they're doing it and what their role is. It takes away a lot of drudgery by design. You pull out all of those types of waste that we described, and the patients are happier. So if you can imagine, as you move toward this new way of delivering care with all of the incentives aligned and the systems you need and the automated tools and everything you have, if everything were working in flow and in sync and in the best possible to-be way, it would be a lot better to work in a practice. It would be a lot better to visit a practice, and the triple aim could then be achieved. So I really want you to encourage you to continue to explore Lean if you're not already using it, and if you are using it, maybe your health system is using it mostly on the inpatient side but hasn't yet been applied on the ambulatory side. Highly encourage you to do that and to reach out to us for any help you may need. Thank you very much.
Great. Karen, if you can, just the last slide, I'll provide your contact information and some more information about our next webinar. I'd like to thank Karen and Jerry for their time today. Obviously, this information is extremely valuable. And again, if you do have any questions, do not hesitate to reach out to Karen or Jerry. Their contact information is here and will be available in the slides as follow-up. And just as a reminder, one more time, you will receive a copy of this presentation and a link to the recording early next week. When you log off, we would love for you to fill out a brief survey. This will help us learn more about what was effective in today's session and what we can improve upon for future webinars. And then finally, in a couple of weeks, we will have our next webinar. It is Tuesday, June 23rd from 12:30 to 1:30 p.m. And we are excited to announce that we are interviewing Rick Schooler. He is the Vice President and Chief Information Officer at Orlando Health, and he will provide his perspective as the CEO on Pop Health Management. With that, we are done with today's webinar. We want to thank everybody for attending. Have a wonderful weekend. This concludes our session. Thanks again.